So let me introduce you to the Turing-Roche Knowledge Series, whose aim is to bring together members of the Turing-Roche networks and the wider scientific community to hear different perspectives on topics in data science and also to build new connections. To get us started, let me go through a couple of slides to give you an intro to the partnership. So as the name suggests, it is a partnership between the Alan Turing Institute and Roche. I guess most of you are familiar with at least one of these organizations. In case you're not, the Turing Institute is the UK's National Institute of Data Science and AI, and it's built around a network of university, industry, charity, and government partners. Roche is a leading healthcare company with a long-term interest in personalized healthcare, and we're one of their growing number of academic partnerships. The partnership was launched in 2021, and its 5-year missions is summarized by our partnership North Star. The goal is to collaborate to achieve a better understanding of patient and disease heterogeneity, essentially why patients respond differently to treatment and why diseases can manifest in different ways in different people. And we're doing this through a stepwise manner, as illustrated on the right. So not on the drug discovery side, but we're focusing on developing new methodologies and working on knotty challenges that occur in large health data sets to generate insights that can lead to improved healthcare. We have split our North Star focus our research into 3 different themes: structured missingness, to deal with missing data, in particular when it displays as a structure; predictive modeling, to construct models that are robust to uncertainty and heterogeneity and that are transparent; and multimodal analysis, to effectively combine different data modalities to improve clinical care. Our core partnership team is pictured here with representatives from Turing and Roche, which is expanded by the research associates funded by the partnership, enrichment students, community scholars, and you can find all the people involved in the partnership on our webpage. Now I'm very happy to introduce you to our speaker, Ioanna Thoma, who is a research fellow at the London School of Hygiene and Tropical Medicine, and she is also a former research associate in the Turing-Roche Partnership, with an interest on improving methods in risk prediction for better health outcomes in biomedical applications. Ioanna, the floor is yours.
Thank you, Maria. I'm Ioanna Thoma. I'm happy to be back at Turing. It's lovely to see some familiar faces in the room. And thank you to everyone present line. I hope you see my slides and you hear me well. Okay. So in the context of biomedical research and prediction modeling, the types of data we bring together is increasing all the time. And their availability and our ability to harness this data is increasing all the time. A very important source of information and type of data is electronic healthcare records. We as researchers, we access this data in an anonymized format in secure data environments. And that allows us to obtain a much more granular idea of the differences between patients and why there is such big inter-individual variation in health outcomes. So that in turn enables precision medicine. By precision medicine, we mean targeted interventions to each individual's needs. So that's a huge enabling factor, electronic healthcare records for biomedical research. And this data gives rise to clinical prediction models. These are models that take diverse inputs and in turn gives us a precise estimate of someone's risk of developing a disease within the next X years. For example, cardiovascular disease within the next 10 years. So we use clinical prediction models in a clinical setting to identify high-risk patients and understand at a much more granular level the differences between individuals. Because there is huge variation. Some people enjoy long, healthy lives, and some other people develop complications quite early. So electronic healthcare records give us linkage with sample banks. We have biomarker panels, genetic data that help us understand the relationships between the outcomes of interest and each person's profiles. So before I get into the details of a broad clinical prediction pipeline, I want you to consider this example. Obesity nowadays kills more people than starvation. And obesity has been linked with a huge public health time bomb, which is type 2 diabetes. Type 2 diabetes, there are approximately 400 million people who suffer with type 2 diabetes nowadays globally, and these individuals have an increased risk of heart attack and stroke. So in settings like that, when we know that there is an increased risk of heart attack or of developing any disease in general because of an underlying health problem, we would like to take as much information as possible, like biomarker data, demographic data, clinical variables such as systolic blood pressure and other, and take everything together, develop a clinical prediction model that gives us someone's risk of developing the disease, of experiencing the disease within the next years. And this is usually done by following a cohort over time. So we actually observe the real outcomes of that cohort, of that population that we are training the model on, and then we can actually evaluate the performance of our model, whether the model has correctly predicted the outcome. This is what I mean by prediction evaluator and prediction accuracy. And of course, not any prediction model is 100% certain about the outcome. And in the concept of risk prediction model, it's good to understand that the risk scores we're using in the clinical setting are usually continuous scores, and we use thresholds or cutoffs below which someone has a lower risk of developing the disease, and above which someone has a higher risk. And this is to inform screening referrals in the clinical practice. So if you have any questions, feel free to interrupt me throughout the talk. And I want to get into a more specific problem in the clinical prediction modeling, when there are some settings where additional covariates might be required to improve risk prediction modeling, the performance of the model. A key challenge in this setting is to determine who should receive this additional data in an equitable manner. So we coined the term fair data collection for risk prediction in settings that resource might be limited and constrained. So this is all in an effort to improve risk prediction modeling. So this additional data might be necessary so that we get a better prediction of risk of someone developing a disease. And there has been studies showing that, first of all, using multiple time point measures can improve accuracy compared to single time point data. And secondly, using genetic data is increasingly coming up in many studies where these genetic risks have been developed for various diseases, such as cardiovascular disease. And this is an extra risk factor that is used on top of more conventional risk factors, such as age, sex, systolic blood pressure, BMI, body mass index, and others. So to summarize what the problem is and what our application is, we are facing the problem of collecting additional data for everyone, for the entire population, is not financially viable, it's not feasible financially. So we need to select a subset of people who might benefit most from this additional data, additional testing. And in order to select the subset who gets these intense assessments, we need to explore different policies. And in my work, during my time at the Turing-Roche Partnership, we've explored different threshold-based policies to select which patients should be chosen for additional testing based on their baseline risk estimate. Please remember that there is a baseline risk. We are depending our policy on. And we have investigated these policies in the context of an integrated risk tool for CVD. So this schematic hopefully helps you understand a little bit better the idea of having a risk score for someone's risk of developing cardiovascular disease. And based on predefined thresholds, we have risk categories such as low risk, intermediate risk, and high risk. And would like ideally to focus our energy and resources on those people whose risk falls in the intermediate risk category, because these people might not be already in the radar of their GPs, and we need to prioritize them for treatment screening. So the subset that takes this extra testing probably comes from this intermediate risk category. And the idea here is that we will use the polygenic risk score, this genetic data, for those people whose risk falls within the intermediate risk category in order to see whether they are high risk and we need to call them for screening or not. Yep.
Does this setup assume that the enhanced model agrees with the baseline model on the low and the high risk end of the scale?
The integrated risk tool doesn't necessarily agree 100% of the time, but if you have limited resources, you want to prioritize people from the intermediate risk category usually, because otherwise those in high risk might be already given treatment. Those in low risk, there's no need for them to be treated up to that point. So let's see what happens with those people whose risk falls in this intermediate risk category. And in our application, we've used data from the UK Biobank cohort with non-missing genotype information. So that was a case that we had a polygenic risk score available for the entire population of interest, but we actually focused on the white British subset of our biobank cohort because there are claims that these polygenic risk scores have been developed using people of white heritage, so they might be not performing that accurately in people from other ethnic groups. The cohort was between 40 and 79 with clinical and demographic variables available at baseline. So there wasn't any repeated measurements over time. We just used data collected at baseline with median follow-up time of approximately 9 years. This is just to say that those people have been followed up, so we know if they have developed CVD or not after the study was initiated. And the conventional standard risk factors for this type of problem usually are sex, age, body mass index or BMI, sort, systolic blood pressure, smoking status, and diabetes. So these are the standard, the baseline risk factors that we've used to estimate the risk of experiencing a CVD event within the next 10 years. And we've also excluded individuals with a known history of CVD, cardiovascular disease, at baseline to reduce confounding. So there was no one with prior history of CVD. And the CVD events were identified using the codes from the International Classification of Disease, following the paper by Ioanna Thoma. So very briefly, to help you understand the methodological part of our study, this is a prediction problem. So the prediction concerns a binary outcome, whether someone's experience is a CVD event within the next 10 years. And this is a variable that takes 0 or 1 based on what is predicted by the model. And for each individual, we have access to a set of covariates xi and a baseline prediction f hat. To assess the accuracy and fairness of different policies, we define P, which is a value of a protected characteristic. This might be ethnicity or age or gender, attributes that we don't want to discriminate against. And we want to evaluate the fairness and the accuracy of the model against these attributes. So a policy is under this context is a function that takes as input the baseline prediction of whether someone experiences CVD or not, and this protected characteristic, and returns a binary value indicating whether someone should receive an intervention based on whether they are low risk, intermediate risk, or high risk. And under the baseline policy, everyone gets a baseline prediction. Everyone who gets a baseline prediction above a threshold, a cutoff delta, gets treatment or gets screening. This is a bit vague. So just to say that we've used a well-established model for CVD which is sex-specific and is used to estimate 10-year CVD risk, which is the Framingham score. And these are the published coefficients of this model. So we replicated this for the UK biobank population, and we actually recalibrated this to reflect specific the biobank, UK biobank population specific risks across gender. And we've used a linear combination of the Framingham risk score, of the baseline prediction, and the polygenic risk score following the papers by Riveros. And this beta, that is the only part we're missing, that was obtained from set-stratified logistic regression models performed on a held out 30% subset. So we performed cross-validation. We used 70% of the data to learn the model, and then we guessed, we predicted the outcomes on this 30% of the white British population cohort in the UK population. For both models, for both the Framingham score and the logistic regression models that include the PRS, the polygenic risk score, on top of the standard risk factors, we use the cutoff of 0.1, 10% so people above 10% are considered high risk. And this is according to the National Institute for Health and Care Excellence guidelines that recommend statins, prescribing statins for individuals with estimated 10-year risk greater than 10%. And we did notice that the integrated models for men, trained separately for men and women, have a better discrimination ability compared to the Framingham score and the calibrated Cox models. So that was a good indication within each group. Here, the stratification is in terms of gender. The probability that an individual who will experience the event has been higher than someone who is not predicted to experience the event at a satisfactory level. And now I want to introduce you to some fairness metrics that we're interested in. And I hope this simple schematic gives you an idea of what we call metrics, error rates in a clinical prediction modeling setting, stratified by a protected characteristic. This is gender again. So unfortunately, not like there's no one dimension that says whether a model is accurate or not. There are at least two, and these are specificity and sensitivity usually, which are defined here. And specificity is useful when we want to cut down unnecessary treatment, while sensitivity, when it's high, means that the model almost never misses a real case, which is quite important for diagnosis, for early diagnosis and intervention. And we also usually in this setting calculate the positive predictive value again from the true positives and true false positives, the negative predictive value, and net reclassification improvement that quantifies the movement up or down in terms of risk categories when we move from the baseline model to using the integrated model. And here are some more interpretation in terms with respect to these metrics. We usually have a trade-off between sensitivity and specificity in clinical prediction models. So when we have high sensitivity but low specificity, the model catches most cases, but still we have many false positives. And when we have high specificity and low sensitivity, we miss some cases, but we have few false alarms. So ideally, for example, when we have 90% specificity in a CVD model, that means that 90% of the people who will experience the disease have been correctly classified, who will not experience the disease, have been correctly classified as low risk, while 10% are missed. So here again, a mean example of who loses out because of false omission rate when we have like false negatives. Depending on the score, someone could have been given treatment if they haven't been a false negative. And if they were given treatment, they might not have been admitted to the hospital, but just because they were omitted from the model, from the model's predictions, they were eventually admitted. And here, this is the definition of a net reclassification improvement, which takes into account the real outcome. So when cases here means the people who have experienced the event of interest, non-cases are people who haven't, and improved cases means that someone who has a higher hazard of experiencing the event has been moved up by using the integrated tool. So it's an improved case. Well, someone who has moved up while they didn't have the event, that's bad. So ideally, again, a CVD model that incorporates an ethic risk might improve reclassification, leading to a positive NRI. Okay. So back to our policies and the way to identify those people who might benefit most from additional testing. So we wrote an algorithm to identify those people whose baseline risk lies within a tolerance range from the high risk category boundary. If the high risk category boundary is 10%, this tolerance level might be 2%, for example. So we take everyone whose risk lies between 8% and 12%. And this is our subset who gets additional testing. And we have explored this with various tolerance levels. Those people get the polygenic risk score on top of their conventional risk factors. We compute the integrated risk score, and then we compare the distributions of risk in terms of gender and age. This is our stratification to explore and investigate fairness. We might want the algorithm offers the option to impose a gender balance if this is desired. So if we want to prioritize the same number of women as the same as the number of men, then maybe there are more men between 8 and 12% whose risk falls within 8 and 12%. So we cut down this number of identified men, for example, to match the number of women that whose risk falls within this range. And here again, the stratified threshold-based policy allows us, which is an extension of this threshold-based policy that applies to everyone, allows us to vary this epsilon, the tolerance level, according to someone's protected characteristic. So if we want to sample more, to identify more women, then we have a higher tolerance level assigned to women. And these are some of our results. We summarize the results in terms of sensitivity. We have sex, age as our stratified groupings. Epsilon is the tolerance levels. When epsilon is 0, this means no one takes the polygenic risk score. Everyone has the baseline score, but when epsilon is infinity, then everyone takes the integrated score. And these are some of the highlights of our results. We have generally substantially higher sensitivity for men than for women under the baseline policy. This is 0.85 and 0.45 for women respectively. So that indicates a baseline and lack of true positive rate parity. As the tolerance parameters epsilon 1 and epsilon 2 increased, sensitivity improved for women. It reached 0.49, but it remained relatively stable for men. So that was an improvement in terms of fairness for women. The lack of true positive rate parity was even more stark when comparing age groups here with with younger groups exhibiting much lower sensitivity at baseline, but as the epsilon increased, we had higher sensitivity for all age groups apart from male 60 to 69 that didn't substantially increase. If you want to have a look again at the numbers, we start with 0.45, 0.85 for male respectively, and that increases for women, while for the sex age stratification, we have this category male 60 to 69 that they actually, their sensitivity gets from 0.97 goes to 0.95, and N is the number of people identified within its grouping to be given the polygenic risk score on top of their other variables. So, discussion. We've noticed that generally speaking, trade-offs in sensitivity and specificity when we integrate a polygenic risk score with demographic stratification reveals some benefits, some which subgroups benefit most. However, when we have these fairness-aware adaptive thresholds or tolerance for different groups, this might present some ethical or implementation challenges if we don't have enough people, a big number of people within its grouping. For example, we don't have a lot of representation. And of course, a full cost effectiveness analysis would allow for a more informed analysis of the health economic benefits across different policies. And some final remarks. Due to a range of factors, we have differential data availability or access to healthcare. Various types of errors are relatively more or less common. So in its demographic group, within its demographic group, which is fine, but it's important for clinicians to take this into account when they interpret the risk scores when we try to use these clinical prediction models in clinical practice. And overall, with clinical prediction models, it's important to ensure that they are developed, they're trained on diverse enough populations. And training the model is not enough. We need to evaluate their impact on clinical decision making in a clinical setting. And another line of work of mine that's ongoing tries to identify the causal relationships between demographic characteristics that might help us identify and correct bias in the algorithm by using counterfactual approaches. So some food for thought. When can we say that the models truly serve diverse populations? That's a difficult question. We're interested in understanding the social determinants of health on top of clinical variables and clinical measures. And that's another important line of work. So while it's well established that our backgrounds and environments affect our risk of developing diseases, these risk factors are largely absent from prediction modeling. So incorporating these extra pieces of information is not an easy task, but it's important if we want to make the statement that our models truly serve diverse populations and help us in the clinical setting. And in my current post, I'm investigating health inequalities via electronic healthcare records for respiratory viruses. And I would appreciate any insights or relevant work you know of. I hope you got some insights from the talk. I'm happy to discuss further and take questions. Thank you.
Thank you. Maria? When you say, so you say we improved the sensitivity for women a bit, but there's still a gap between men and women. So in this case, you're not using thresholds that are different for the two groups, right? Because then you could fix it if you just calibrate it for that, but you don't want to use that because of ethical implications.
Yeah, it's not the same number of people within this 30% that we've used to learn the model, the integrated model. So we have a different number of men, different number of women, different number of people whose risk falls in the intermediate risk category. So that results in having higher or lower error rates. More people are falsely identified, or some people are omitted falsely while they have developed the outcome. So that's not like a methodological approach to fix necessarily the differences in sensitivity. We're trying to identify, the scope of this work was to identify which subgroup might benefit most from the genetic data. So that's an exploration, first exploration to see what sensitivity looks like in each group. And then we take it from there now that we see that there is actually a lack of demographic parity or anything else. Then we can say, actually, we can develop a more stochastic policy that chooses subgroups according to the results we have obtained up to date. I don't know if that's briefly give you a
Mm,
better understanding.
a bit.
Yeah.
Thank you.
Any questions online? I don't see. I have lost my mouse, so cannot really bring anything up.
No questions.
Okay. I'm happy that everything was clear. Yeah, I don't want to keep people from their food, from their snacks. So
Yeah, thank you so much, Ioanna.
this work will be presented in the European Workshop of Algorithmic Fairness in a few weeks, and you can check the proceedings of the conference afterwards, and it's gonna be published, so you can see what I've briefly described written in this paper, and there will be follow-up analysis. So keep if you're interested. Thank you.